Hi, everybody. Today we're going to talk about the H's and the T's for our pediatric population. Okay? So, because they're so involved, we're going to break them up a little bit and talk specifically about hypovolemia and hypoxia today. And then in the next upcoming videos, we'll talk about two more and so on. But opening this up, I do want to let you know what the mnemonics are for the H's and the T's. American Heart was just so helpful in providing us with the H's and the T's. When I taught my ACLS here on YouTube, we went over the H's and the T's. I did not do that with PALS, specifically because they're more involved. There's an extra one of them in each H and T. And so I knew that I wanted to make some videos to just talk about the H's and T's. But they are, if you want to jot them down, hypovolemia, hypoxia, hydrogen ions or acidosis, hypoglycemia, hypothermia, and hypo and hyperkalemia. And that one's going to be huge because it's just so important to the heart. Then for your T's, the mnemonic is tension, pneumothorax, cardiac tamponade, toxins, cardiac thrombosis and pulmonary thrombosis, and then finally trauma. So there's your H's and your T's. Let's talk today just about hypovolemia and hypoxia. Hypovolemia is, just so you know, hypovolemic shock is the most common form of shock. All right, so if this is the problem that your patient's suffering from, just know it is the most common form. And interestingly enough, the most common reason for hypovolemic shock is diarrhea. That was interesting. Now, what are all of the causes? Let's go through them. Vomiting, diarrhea, hemorrhage, a lack of intake of fluids. They're not taking them, they're not getting them, but there's a lack of intake there. How about a loss of maybe a pathologic urinary loss that you would receive from diabetes insipidus or diabetic ketoacidosis, right? So either one of those. And then how about a translocation of the body fluids that you would get with burns or small bowel obstruction? So all those can be reasons why your patient has hypovolemia. One of the things, remember, we're going to do our assessment. We're going to do our initial assessment. We're going to do our primary assessment. And we're still going to do our secondary assessment. We have a lot we need to ask the caregivers, right? But I want to talk about that secondary assessment right now because, the primary assessment. So remember, it's A, B, C, D, and E. Your airway is typically going to be normal with your hypovolemic patient. Your breathing will be increased. And as baby progresses, if we're not fixing the problem quick enough, the breathing might also be labored. C stands for circulation. That's going to be what you're going to see with when you go to do your assessment. That's the big one, is circulation. So what would I see? Well, we're touching the patient now in this primary assessment. So we're going to palpate a peripheral pulse, but they'll be weak. They're hypovolemic. They're dehydrated. They're going to be weak. What's their cap refill going to look like? Greater than 3 seconds? They're going to be tachycardic. And their systolic blood pressure might be showing hypotensive. So, remember that little formula, 70 plus, 2 times the age in years. That'll be your guide, right? Let's go to D. D shows their level of consciousness, and as they progress with hypovolemia, they're going to show a decreased level of consciousness. And E stands for exposure. That's your head to toe assessment. We're touching the patient. Head to toe, what am I going to see? I'm going to see pale skin. It's going to be cool. It could be mottled. They're also going to be showing, like I said earlier, the cap refill will be greater than or equal to 3 seconds. Right? And so that is your primary assessment. Now, what are we going to do? I did want to add something in your primary assessment, your head to toe assessment under E. I forgot to add their eyes will be initially normal if they're just mildly dehydrated. But if they are starting to advance to a more serious dehydration, the eyes actually will appear sunken. And I think the tears, that was another one I wanted to head to toe remind you of. Initially, it might be normal. Their tears, if they're crying or coming out, everything's normal there. But if it becomes severely dehydrated, the tears will show no tears coming out of their eyes. Mucous membranes is another one. It'll be normal at first, but they'll appear very dry as they become more dehydrated. So we want to fix this problem. How can we fix the hypovolemia? Well, it's recommended that the doctor would probably order a fluid challenge, and that is 3 of them, and they're bolus at 20 milliliters per kilogram over 5 to 10 minutes. What are we going to use? Depends on why they're hypovolemic, but the doctor might order normal saline. He might order lactate ringers. If he wants a combination of the two, he might order isotonic crystalloid. Remember I mentioned hemorrhage. If this fluid administration is showing, the baby is showing to be refractory to that, then if it's blood loss that we're dealing with, we might want to consider packed red blood cells also. And how much would we expect to give? 10 milliliters per kilogram. Okay, so how are we going to show if they're what are they going to look like if they're showing improvement? Because remember, we're still going to be doing our patient assessment triangle. Every time we do something, we're going to be evaluating, identifying to see if there's improvement, and intervening if there was no improvement, to fix the problem. We're going to always, every time that we do something, be evaluating, identifying, and intervening. So what's it going to look like if they're improving? Well, their heart's going to normalize, right? The heart rate's going to normalize. Their respiratory rate's going to normalize. Their level of consciousness will normalize. So all of these things will start to normalize. And that's how we're going to know, we're fixing the problem. We're getting closer to fixing the problem. And that is hypovolemia. Very involved. Let's talk about hypoxia. Hypoxia is we want to work on this quickly because they can go into respiratory distress or failure very quickly. So once we realize or recognize, that they might be hypoxic, we want to fix that problem. What would cause them to be hypoxic? you already know because we went over the respiratory illnesses in our PALS class that we did a couple of weeks ago. And that was upper airway obstruction, lower airway obstruction, lung tissue disease, and disordered control of breathing, which was neurological, right? So how would we know which one it is? Well, one thing we can do is auscultate, right? We can auscultate for hearing stridor or wheezing, decreased breath sounds, rales. These are the things that we would be looking for in our auscultation. We want to look at their respiratory rate. Is it increased? Is it lower than it should be for normal? You know, so all of these things are things we want to look at with hypoxia. How are we going to fix it? How we're going to fix it is when we do our initial assessment, A, B, and C are going to be extremely helpful. We are going to make sure the airway is patent. Remember, the anatomy of the airway, we went over that. And so we want to make sure the airway is patent. If it's not, we want to remove that obstruction. If they need suctioning, we want to suction them. If they need their head tilt chin lift, we're going to do so to open that airway up. Remember, if they have a possibility of a cervical injury, we could do a jaw thrust. If that's not enough, American Heart says we can do a slight head tilt. Okay, very slight. We could put in an oral pharyngeal airway or a nasal pharyngeal airway, and I did not go over that. I want to go over that because that is a question on the test a lot of the times, is how do you know what size to put in? Good question. Oral pharyngeal airway from the angle of the mouth to the end of the mandible, whichever one is closest, that's the one we're putting in. For the nasopharyngeal airway, from the nair to the earlobe. Okay, so from the nair to the earlobe. Whichever one is closest in size is the one we're going to put in. Okay, breathing. So we're going to monitor their saturations. We want it at 94% or higher. We're going to provide oxygen as needed. Guys, there's a lot of modalities there. Non-rebreather, probably. If they are in hypoxia, depending on what the reason is, we might even have to consider intubating them. Always be ready. We might want to give them inhaled medications, right? So depending on what the reason is that they're hypoxic, we might want to consider a bronchodilator. Whatever the doctor orders is what we're going to give them. We want to assist in their ventilation, be ready for that bag mask device if they need that. And then C stands for circulation. This is your initial assessment. Remember A, B, and C. And circulation here, we want to monitor their heart rate, their heart rhythm, and their blood pressure. Remember that little formula, 70 plus 2 times their age in years. Monitor their blood pressure. So also too, in circulation, make sure you get an IV or an IO established really quickly, early on in this process of hypoxia. All right. Indicators that you're probably fixing the problem is an improvement in that heart rate, an improvement in that rhythm, right? It's becoming back to a sinus rhythm, normal sinus rhythm. It's not tachy, it's not Brady, it's a normal sinus rhythm as well. We want to look at their blood pressure as well. So if we're providing the correct oxygen, using the right modality, it's a good chance that we fix that problem. Something else I just want to add, what carries oxygen? Yeah, so if they had blood loss and we're providing all the oxygen we can and their still saturations are below 94%, Might want to consider the fact that they, need some red blood cells. Okay? So that's something we want to always keep in the back of our mind. Have to really critically think with these babies, don't we? So we've reviewed today hypovolemia and hypoxia. And in the next video, we'll go over hypoglycemia and hypothermia. And then in the following video, we'll finish it up with hydrogen ions and hypo and hyperkalemia. All right? So I'll see you then. Have a good day. Bye-bye.